subarachnoid hemorrhage is basically blood in the space surrounding the brain. It usually happens when a weak spot, aneurysm, in a blood vessel on the surface of the brain breaks and leaks. As blood increases in the brain and inside the skull, the pressure on the brain increases. This can lead to brain cell damage, life problems, and disability. When the aneurysm is located in the brain, it is called a cerebral, intracerebral, or intracranial aneurysm. A brain aneurysm usually develops over a long period of time, and may not cause any symptoms until it ruptures. Most cancers occur after the age of 40. Trauma is the most common cause of sudden SAH, and 75% to 80% of sudden SAH involves brain damage. Other causes of SAH include aortic aneurysm, AVM, central nervous system-related pulmonary embolism, and carotid artery dissection. Factors that increase the risk of SAH include high blood pressure, smoking, oral contraceptives, pregnancy and childbirth, and cocaine abuse. Decompressive craniectomy is a standard neurosurgical procedure for refractory intracranial hypertension. Patients with severe aneurysmal subarachnoid hemorrhage, ASAH, are prone to develop intracranial hypertension and sometimes require decompressive craniectomy. However, the clinical utility of decompressive craniectomy after SAH remains unclear. Below, we present a systematic review and meta-analysis summarizing published studies on decompressive craniectomy in patients with SAH. A decompressive craniectomy is defined as removing a large portion of the skull and opening the dura mater to reduce intracranial pressure. A primary decompressive craniectomy is defined as not replacing the skull immediately after the mass lesion has been removed. Secondary decompressive craniectomy is the removal of bone tissue after treatment for patients with elevated ICP.